Good afternoon, everyone. Am I audible to you? Hello. Am I audible to you?
Yes, sir.
Is there any disturbance? Okay. Today we are going to see a small topic on typhoid fever. So call it as enteric fever. It is of two types: the paratyphoid or typhoid. And paratyphoid is usually caused by paratyphi A and paratyphi B. Typhoid is caused by salmonella typhi, which is more common, 90%. Okay. So salmonella, you'll see the uh, organism details. Like it is a gram-negative organism, rod-shaped bacilli. Usually it is intracellular and it is a motile organism. That is, it is having flagella, it moves with the help of flagella and belongs to Enterobacteriaceae family. And the important part for us is the antigenic structure of the salmonella. It consists of flagellar antigen H, antigen O, and surface antigen Vi. Please remember that it's a surface antigen H, O, and Vi. These three things are important. Okay. And you'll see the O antigen. It is a polysaccharide which is a part of LPS of the cell wall and it is heat stable. O antigen is shared among various salmonellas and usually appears and if the patient is having infection, that O antibodies and antibodies against the O antigen will appear on day 6 or 8. And coming to the H antigen, it is flagellar antigen, it is heat labile. And Vi antigen, this is most important, it is called polysaccharide capsular antigen. This is the antigen which is more responsible for the virulence of the organism. Okay, and we'll see the transmission. As you know that salmonella typhoid is a fecal-oral route transmission. Predominantly, typhoid is food and waterborne disease. Milk products, vegetables grown in sewage irrigated farms, and meat products are the common sources. And the reservoir is a human. And peak incidence is between 5 and 15 years of age group. And this is the size of the organism, 10 to the power of 5 to the 10 to the power of 9. And the important point here is incubation period. It takes 7 to 14 days. Transmission is fecal-oral route. These 2 points are important. Coming to pathogenesis. This organism must survive a gastric barrier to reach the small intestine. Once it is, as you know that its route is a fecal-oral route, and once it enters into the stomach, it should survive the gastric barrier. Like use of antacids, proton pump inhibitors, H2 blockers reduce the infective dose. The surface VI polysaccharide capsular antigen found in Salmonella typhi interferes with the phagocytosis and a virulence trait encoded with PHOP gene gives ability to multiply with the macrophages. Okay, this is the pathogenesis part, as you should know how it causes infection. First, it penetrates the mucosal barrier of the intestine through M cells and reach submucosa. In submucosa, it multiplies in macrophages and lymphoid follicles and reaches the mesenteric lymph nodes. Once it reaches the mesenteric lymph nodes via the bloodstream, that is called primary bacteremia, and multiplies in the reticular endothelial system like liver, spleen, bone marrow, and gallbladder. First thing, it penetrates the mucosal barrier of the intestine and through M cells and reach submucosal, from mucosal to submucosal. In submucosal layer, it enters into the macrophages and there it multiplies, and lymphoid follicles also, and via that it reaches the mesenteric lymph nodes. From there it enters into the bloodstream, that is called primary bacteremia, and multiplies in the reticular endothelial system, that is liver, spleen and bone marrow, gallbladder. Okay. From there, spill occurs into the blood, causing secondary bacteremia, which marks the onset of clinical features. Can someone tell me what are the clinical features you see in typhoid fever?
Step-ladder, fever, rashes.
Yes. What is first one is fever, which is a high grade. Okay. Yeah, high grade fever.
Rose spot.
Yes. Coating on the tongue, whitish color coating on the tongue, and patient look toxic. This is a clinically you can easily make out typhoid fever if a patient is having all these things. So these things will occur when there is a secondary bacteremia. Okay. From there, the liver bacilli also secrete through bile and enter into the intestine and infect the Peyer's patches. What is the complication with this? Peyer's patches infection in terminal ileum. Sorry.
Typhoid ulcers.
Typhoid ulcers, yeah. Typhoid infection will cause typhoid ulcers, that is correct. But if it infects the Peyer's patches, later on the patient will develop intussusceptions. That is one complication, you should remember. Okay, in the terminal ileum. And then from there it causes hypertrophy of the Peyer's patches, sloughing of the overlying epithelium, leading to typhoid ulcer followed by necrosis and perforation. This is another fate of the ulcer, causes necrosis and perforation. But hypertrophy of the Peyer's patches will cause chances for the intussusceptions. Okay, and this is the pathogenesis of the typhoid fever. First, it enters into this terminal ileum, M cell, and then Peyer's patches, mesenteric lymph nodes, reticular endothelial system, widespread dissemination. This is the secondary bacteremia. So this is a point where you get clinical features in the patient. So we'll see the clinical features part. The hallmark of the enteric fever is fever starts as a low grade and then progress to high grade fever. And the pattern is step ladder pattern. Day by day, the fever spike, it goes up. And usually the pattern will end after the first week. And this pattern differentiates from viral fever, where the peak is usually the onset of the disease. If it is a viral fever, the peak usually comes in the first 1 or 2 days. But in Salmonella typhoid infection, the peak comes after 3 or 4 days of infection. Gradually it increases and reaches the peak. In the absence of treatment, fever may continue for 3 to 4 weeks, followed by a natural remission or by development of further complications that we'll see later on. And these are the clinical features. We rated that clinical features based on which comes the most common. That is a high grade fever is the most common, that is 95%. Coating of the tongue, anorexia, loss of appetite, that is vomitings, hepatosplenomegaly, both will be there. And the patient will sometimes have a diarrhea, and patient may look toxic, abdominal pain, and especially if someone said that there is ulcers. In those cases, there will be severe abdominal pain and pallor, splenomegaly, constipation, and headache, jaundice, all these things. Finally, this is a complication also. This is called perforation. Chances are 0.5%, but you should be very conscious. In the first week, usually raising fever with or without chills, but mostly in typhoid fever, chills are more common. Sometimes they'll have relative bradycardia, dull expression, or a less toxic face because it's a first week, during the first week, and damp hair, like odor from the patient. Coated tongue is most important. Tender and doughy abdomen on palpation. Skin may be dry with a little sweating. diarrhea in younger children, and constipation in the older children. Whereas in the second week, this low-grade fever will become high-grade fever, and you can see the road spots, tender spleen, which is palpable, tender hepatomegaly, worsening of the respiratory problems. There is a cough or any breathlessness also sometimes they may present. And this is the faint salmon color macules seen over the trunk, appears in crops that is 10 to 15, usually seen after 7 to 10 days of illness. But in Indian setting, these road spots are not that much visible because of dark colored skin. And usually you can differentiate it by applying a pressure. It fades on pressure. And once you apply pressure, it fades out. Difficult to see in dark skin individuals. It's called faint salmon color macules. In third week, you can see the organ growth, that is hepatosplenomegaly, and complications we all you see in the third week, that is intestinal bleed or perforations and features of peritonitis. Can someone tell me what are the features of peritonitis or when you suspect peritonitis? On inspection of the abdomen itself, you can make out peritonitis. Can someone tell me?
Distended abdomen.
Yes, distended abdomen causes are there. Multiple causes are there for
Tenderness of abdomen.
yes, tenderness of the abdomen. Sorry.
Rebound tenderness.
Yes, rebound tenderness. Correct. Rebound tenderness. Where you get rebound tenderness apart from this? Appendicitis. Correct. Someone is telling appendicitis. You get rebound tenderness. But classically, if there is peritonitis, apart from leave about rebound tenderness. But on inspection, you say one point. Do you remember? All quadrants of the abdomen moves equally with respiration. Remember or not? In inspection, you say all quadrants of the abdomen moves equally with respiration. That is not possible if there is peritonitis. Okay. Movement of the abdomen will be restricted. And if that is very severe, the patient may land up in sepsis and for later on septic shock. If the child is in shock, again, altered sensorium, all those complications, neurological complications. Okay. Okay, fine. We'll see investigations part. Okay. First thing is cell count, total leukocyte count. Either it may be normal or decreased, 20 to 25%. Differential count, relative lymphopenia will be there, and absence of eosinophils are the characteristic features. And transient thrombocytopenia may be seen in 10 to 15% of the patients. There may be mild elevation, mild to moderate elevation also will be there for SGOT, SGPT, bilirubin, or the liver function test. Okay. That is liver function test. On cell count, you have a total leukocyte count may be decreased or normal. DC, the classical thing is relative lymphopenia and absence of eosinophils, and transient thrombocytopenia may be seen and with elevated LFT. And when you do culture, bacteremia occurs early in the disease. Blood culture is usually positive in about 90% cases when you do in the first week, and it figures fall down once it weeks progress. That is, and second week 75%, and third week 60%. Thereafter, chances are less than 25%. However, yield is very poor if with the usage of antibiotics. Once, if you want to take a blood culture, you should take it before giving a first shot of antibiotic. Even one dose of antibiotic will reduce the volume of the bacteremia. Okay, the optimum volume of blood culture is usually depends on the vial. It is for general usage. For adults, it is 10 ml. For children, it is 5 ml. But it varies from the bottle size also. And again, you can do all this urea negative test, Mantos and mannitol and maltose fermentive test. If the first culture is negative, subculture should be repeated and culture declared negative after incubation for 10 days. Okay. And the gold standard test is bone marrow aspiration. If you want to confirm that, because the high sensitivity, the bone marrow is a gold standard test. Usually we don't do because it's a more painful procedure for a patient. Even blood culture is more than enough. But if you can't rule out, but the patient is having continuous symptoms of typhoid and enteric fever, then we'll go with this procedure, bone marrow aspiration, because it's having very high sensitivity of 80 to 95%. It has advantage over blood culture with even after usage of antibiotics, the chances for positivity are there. In the first week of illness, concentration of bacteria is 5 times more than the blood. So the chances for getting positive result is more in bone marrow aspiration. Even in third week, it is 150 times more concentrated than blood. And in stool culture, usually positive in 30% cases because of irregular shedding. Several stools. Okay. But stool culture is not advised because you need to take several stool samples. It needs to be processed within 2 hours after collection. These are some drawbacks of that. And urine is not recommended because it's of poor sensitivity. And as you know, these are the common tests we do, antigen antibody agglutination. There's a WIDAL test. This is mainly to detect O and H antibodies in patient serum. And antigens used in this test are O antigens of Salmonella typhi and H antigens of Salmonella paratyphi A and B. And O antigens predominantly IgM will appear on 6th to 8th day. This is important. O antibodies predominantly IgM will appear on 6th to 8th day. H antibodies both IgM and G appear on 10th to 12th day. WIDAL test can be performed by a tube test and a slide test, two types. Tube test is preferred over the slide test because it is having high sensitivity. You need to remember these 2 points are more important. O and H antibodies when it will appear. And interpretation of the WIDAL. First thing is when you see a report, any titers above 1:160 of both H and O titer is the cutoff. So if the value goes above 160, 1:160, then only you can consider it as a positive WIDAL test. And there are some limitations also. WIDAL test is moderately sensitive and moderately specific. In 30% blood culture proven cases, WIDAL test is sometimes negative. So we should know about what is false positive and false negative scenarios. Like false positive is when if the person is previously immunized, it may show as positive. Cross reactivity with non-typhoidal salmonella. This WIDAL test is having more amount of cross reactivity, and sometimes technical errors also lead to false positive. And another infections also sometimes present, like if the patient is having another infections apart from the typhoid, it may show in the WIDAL test. Infections like malaria, brucellosis, and other enterobacteria infections, dysentery, pneumonia, and dengue fevers. And coming to false negative, if it is a carrier, person is a carrier, if the treatment was early started treatment and hidden organisms in bone and joint, sometimes it may be in dormant state. And again, technical errors also can be considered as false negative. And serological test, usually Typhoid dot is the newest method where we do both IgM and G against membrane protein antigen, because it is very simple, rapid and economic test with high sensitivity and specificity. Apart from WIDAL test, you try to remember this Typhoid dot also. Yeah, it usually comes false positive if there is a previous infection. Another test is IgM dipstick test. It detects IgM antibodies against a lipopolysaccharide of antigens, and it requires incubation up to 3 hours of with less sensitivity. And another test, these two we usually don't do, but Typhoid dot is the latest one we are doing. So try to remember WIDAL and Typhoid test. Okay. And antigen detection test, ELISA for VA antigen, agglutination, immunoassay, and PCR. Coming to the management, this is important. The first line of drugs are before ampicillin, chloramphenicol, cotrimoxazole. In 1990s, this typhoid bacteria became resistant to all these three drugs. So that's called multi-drug resistant typhoid. Then they started on ciprofloxacins, and then third generation cephalosporins, everything. Now, cephalosporin third generation is the treatment of choice. If someone asks you what is a complicated typhoid, they should remember all these points like severe vomiting, abdominal distension, that is if the patient is in shock, poor oral intake, splenic abscesses, cholecystitis, hepatitis, all these things are the latent complications. This is the general management of the typhoid fever without any complications. The first line drug and the second line drugs. If it's a fully sensitive, the cefixime is the oral drug we use. Daily dose is 20 mg per kg per day, and you should continue for 14 days. If you are admitting the patient, ceftriaxone is the counter drug for the oral cefixime. And second line drug, chloramphenicol, trimethoprim, sulfamethoxazole, and amoxicillin are the combination. See, the parenteral drug is the ceftriaxone for the cefixime oral. The ceftriaxone dose is 100 mg per kg per day. You should continue for 14 days. If there is a clinical suspicion of typhoid, you think about whether it's complicated or uncomplicated. If it is complicated, start on IV ceftriaxone, that will have better results. If it's uncomplicated, you can go with oral cefixime. And this you should remember. After treatment, clinical course, clinical failure, or clinical improvement. This you should assess after the treatment. Clinical cure means that it's a resolution of typhoid symptoms within 7 days. Then you can continue the same treatment till 14 days. And if there is a failure, there is persistence of more than 2 symptoms. This is the latest drug if there is clinical failure. And then if there is a clinical improvement, partial resolution of illness, continue the same treatment till 14 days. And coming to relapse, there is a recurrence of fever and clinical features of typhoid fever within 30 days of completing the treatment, along with the isolation of the salmonella typhi from blood. This is called relapse. Relapses are more common with beta-lactams. Fluoroquinolones are demonstrated better in eradication of salmonella and thus reduce the relapses. And for carrier treatment, the carriers are usually asymptomatic and shed organisms in the stool. Although 5 to 10% of adult patients may shed bacilli up to 3 months after acute attack in the children, they are very rare. Therefore, a routine screening for carrier state in children is not recommended. Thank you.